Good morning. It's a real privilege to talk to this workshop dedicated to Bob Gillies. I met Bob Gillies in the 90s at Fox Chase Cancer Center. We have been talking about Bob Gillies, the radiomics guy, but he was there was a Bob, the metabolism person, and he came to visit us in Fox Chase Cancer Center. I have just started work with Truman Brown. Bob was interested in measuring pH of the brain. We were using phosphor spectroscopy to also measure the pH. And many years later, when I joined the University of Miami, I heard the concept about the concept of radiomics, and this was perfectly aligned with the quantitative imaging work which I was doing. And then I reconnected with Bob. And as they say, the rest is history. We obtained 2 R01s, and a lot of this work I'm going to present today. And in my I also wanted to share another memory from the meeting which Mary Ellen and John were talking, Houston of 2014. After the meeting, we all gathered in the lobby of the hotel and were having a drink. And at one point, I saw a big crowd being gathered around the bar area, and there was Bob in the middle of it. And there was a very heated discussion, a huge brainstorming going on. I was sitting next to Larry Clark, and he leaned to me and he said, "I'm sure many R1s are coming from this discussion," and probably that happened. In my presentation today, and I'm going to use the word habitats a lot. And every time I say this word, I think about Bob. And I think as a way of paying a tribute to his legacy. And going back to prostate cancer and radiation therapy, it's well understood that prostate cancer exhibits, in prostate cancer, the clinical prognostic factors such as T category, PSA, Gleason score, explain only a fraction of the observed variations in the clinical outcome. Genomic signatures have been introduced in clinic to help the clinicians to improve patient risk classifications, but both histopathology and gene expression are subject to the biopsy sampling error, and prostate cancer exhibits spatial heterogeneity, which confound both this clinical and genomic assessment. And that's why the concept of habitats is a perfect concept, which was introduced to characterize and map this tumor heterogeneity. And in my group, we have generated a way to map these habitats. And the goal was to reproducibly locate and classify the habitats using multiparametric MRI of the prostate, and to use that for diagnosis in targeted habitat biopsies, as well as in radiation treatment by identifying the areas for delivering a radiation boost. So we devised a habitat risk score algorithm that assigns on pixel by pixel basis a score from 1 to 10 in increasing fashion with tumor heterogeneity. And in my presentation today, I will discuss briefly the habitat risk score, as well as the comprehensive implementation and integration of HRS in our radiation treatment of prostate cancer patients, starting from the targeted biopsies, the HRS for gross tumor volume, GTV delineation, the tumor delineation, that's how it's used in the radiation oncology, and also share some radiomics model for prediction of the patient outcomes. So we developed HRS using the quantitative perfusion and diffusion image sequences of the multiparametric MRI, and we displayed that HRS as a heat map. And this is prostate, and these are the all pixels with HRS1, and we can see how we're going with HRS3 and 4. This area, these volumes are getting smaller and smaller, and maybe there's a couple of pixels of HRS10. And we displayed these maps as the overlays as composite maps as it's shown here. And it's directly obvious which are the areas in these patients which we will need to target with the biopsy. We developed HRS in correlation with the histopathology, and these are the transverse samples of radical prostatectomy tissue from a patient with the prostate cancer, and this is the corresponding HRS maps displayed over the T2 weighted image, and we can see how heterogeneous is this right lesion here, spanning a Gleason score from 3+4, 4+3, and going to 4+4, 8, and how well the HRS actually reflects this intensification. That's true also for the anterior lesion here, which is also quite heterogeneous. We evaluated HRS 6. This is the volumes in the prostate which have scored by HRS 6. So we correlated these volumes with the prostatectomy ROI's volume, and we can see a very good correlation between HRS 6, in fact, with the slope of 1, with the prostatectomy tumor volume. We also evaluated the performance of HRS 6 in relationship to cancer versus no cancer, Gleason larger than 7 or equal 7 versus Gleason 6 and no cancer, and Gleason larger than 8 and the rest. In all of this comparison, HRS performed quite well and also outperforms the PIRATS. This is the black line here, AUC here, and the PIRATS is a standard way of scoring the prostate by radiation by the radiologist. So inspired by these developments, we implemented HRS in a targeted fusion, MRI fusion biopsies. This is the HRS, this is the prostate, and this is the needle, which is targeting the area of HRS. Here we got the sample, and we put this green bar here to indicate where the sample was taken for co-registration with the tissue and genomic expression. This is how we have implemented our radiomics pipeline. This is the needle track here, the green dot, and this is the surrounding HRS. And now we can automatically, from that area, extract series of radiomics features related to histogram or also the texture features. And again, I want to point out that the tissue sample and the consequent genomic expression is coming with quite well co-registered with the area where we extracted these radiomics features. And this is one our first papers, which we published with Bob, which we have a correlation between genomic and radiomic features. These are 64 of 5 genes which are expressed on 3 commercial classifiers, CCP, Decipher, and GPAs for prostate cancer diagnosis. We can see the strong correlation which exists between genomic and radiomic features. More importantly, these red bars here indicate genes which are upregulated on the classifiers and the blue which are downregulated. And we can see how well the radiomic features split the genes by function almost perfectly, indicating a strong genomic signal which is present in the radiomics variables. So we have comprehensively implemented HRS in our clinical trials in radiation oncology. This is an example of a schema of the Blaston trial. We have also LEAD and HIGH trial, which are very similar. We acquire multiparametric MRI. We have a battery of biomarkers which are collected from blood as well as from the biopsy. In this particular trial, the patients are randomized by 2 different ways to deliver a high dose boost. And I just want to point out that we acquire imaging at 3, 9, and 2.5 years after the treatment, as well as a biopsy at the end of the treatment. So this is, we have implemented HRS6, which was the volume very well correlated with the pathology volume in for defining of the GTV in these trials. This is the 3 consecutive slices of a patient, the HRS, and this is the HRS6. And my colleagues in physics have generated also automatic plan using the rapid plan, and we can see how we have automated the whole process from identifying the GTV and generating the plan, which brings a very needed standardization in the field of boosting of the dominant lesion in the prostate. So again, going back to the imaging, we acquire 5 series of multiparametric MRI. The diagnostic, we acquire imaging prior to treatment, which we use for fusing with the CT, and then a 3, 9, and 2.5 years. And this is the hypointensity here indicates the area of the tumor, which is also present on the planning MRI. We can see after treatment, the prostate has shrunk and this hypointensity has disappeared. And of course, we acquire all the other sequences of multiparametric MRI. This is the T2 sequence, hypointensity, the ADC, the hypointensity again of the tumor, and this is the early enhancing DCE image where we can see that the tumor lights up. Very interestingly, on the 3 months, we can see this dark area here, which indicates the tumor was completely obliterated. So the prostate has 2 distinct zones beside the tumor, a bright rim, which is called the peripheral zone, and the dark center area, which is called transition zone. In our approach, radiomics approach, we collect data from all of these zones, not only from the tumor, but from the normal appearing tissues. And this is an example how we analyze the data. This is the ADC changes. This is the GTV, normal appearing tissue in transition zone, normal appearing tissue in peripheral zone. And the ADC in the tumor is very low relative to the normal tissues. And of course, this is related to the restricted diffusion in the tumor. The normal appearing peripheral zone is very high because most of the peripheral zone consists of the glandular tissue, and the prostatic fluid in this tissue give rise of this high ADC. Post-treatment in the area of the GTV, the restricted diffusion is gone. We see that the ADC increases. And again, this is related to the tissue changes which happen after prostatectomy, after the radiation treatment. Meanwhile, in transition zone, the ADC decreases and possibly recovers and follows up. And again, this is related to the fact that the radiation, due to the radiation, the neoplastic glands are atrophic and they squeeze the prostatic fluid, which was giving this high signal to start with. And we have generated several models using these quantitative characteristics we obtained from the clinical trials. This is one of the model which predicts the post-RT biopsy positivity. This biopsy positivity is very strongly correlated with biochemical failure. And because prostate cancer has a very high, long natural history, we can use that as a surrogate measure for failure. We analyzed 25 patients, and 4 of them had post-treatment radiation, post-treatment positive biopsy. And these are the 4 features which we found to be related to that outcome. The ADC is low, 2 ADC features which are low in the positive biopsies patients, and VE, which is related to the DCE, high in these patients. And this is the model generated, which has a very high AUC, but most importantly, all the 4 patients which were true positive in the confusion matrix, they were properly assigned by the model. Another development is we try to predict CTC counts, the circulating tumor cells, cells which are detectable in peripheral blood, and it has shown that CTC indicative of metastatic risk and significant biomarker for response of prostate cancer. And we analyzed 71 patients. And again, these are the features which were selected for building of the model. Again, we can see that in high, with the dichotomize the CTCs by a threshold of 5, and in the patients with high CTC numbers, the time of onset, this is from the DCE MRA, and the HRS volume is higher, while the T2 is lower, which is very which is very intuitive to what we know about these signals in the imaging. So again, we obtained a pretty reasonable model. And at the end, we have been working on prediction of PORTOS. PORTOS is 24 gene classifier to predict response of treatment. And again, we had modest success modeling PORTOS, but we believe with adding a more clinical information, which can possibly improve. I just want, in conclusion, to mention, to summarize that we have developed a HRS approach. HRS automatically segments 3D volumes at risk for biopsy, for extraction of radiomics, and for the GTV. And I also hope I gave you an impression of the type of models which we have been developing, and we are developing a larger repertoire, which we hope that will provide to the radiation oncology, not only with HRS6, but with another layer which we can provide the prediction of this model. And in conclusion, I would like to thank my group, past and recent members, the funding, past and recent, and ago. And again, these are the 2 grants we obtained with Bob. And I'm very thankful to Bob, and we miss him. Thank you.